Hello and welcome to the Local Alcohol and Drug Planning Committee for Jackson County. My name is Eric Geyer. Technically, I chair this meeting, but really Sarah Smith has been doing the lion's share of the work and carrying this group forward. So very grateful for that. Rochelle, I believe our first order of business is that we will begin with a roll call of membership and also introduce our guests and staff. So Rochelle Scott, thank you.
Okay, Jack Adkins.
Present.
Tiffany Atkinson. Eric Geyer.
Present.
Justin Hahn. Rosemary Jernigan.
Here.
Michael O'Malley. Brandon Orr.
Present.
Heather Field. Nick Wrighton's excused. Sarah Smith.
Here.
Mary Wallace.
Present.
Do you want me to go through and introduce the staff, or should we have them introduce themselves?
If you would, in either one, however, I'm not sure which staff members we have present, Rochelle.
Okay.
So if you wouldn't mind bringing them up to see who we have.
We have Stacy Brubaker. Let's see, Dr. Mann. I think that's it. Oh, and Dr. O'Keefe.
Excellent. Thank you for all of that. All right. Our first order of business today is the approval of the meeting minutes for September of 2022. Would entertain discussion. Hearing none, I would, Sarah?
I'll move to approve with the correction that in the La Clinica segment, I think it said 150 doses of naloxone out, but it's actually 850.
Okay. So we have a motion to approve with the noted amendment. Do we have a second?
I'll second.
And we have a second from Mr. Orr. All in favor of approving the minutes, please say aye or signify by raising your hand as a member. All opposed? Hearing none, the minutes are approved. All right. Our second item of business is discussion and deliberation of potential applicants to fill the current vacancy. And let's see, Rochelle, I believe we have one current applicant that we would like to potentially discuss and deliberate on.
Yes, just one.
And who is that today?
Courtney Olcott.
Okay. So in regards to Courtney Olcott, I will open up discussion regarding her membership.
Should I actually knock off then?
Courtney, we certainly want to respect wherever you want to be on it. It can be awkward to hear people discuss your membership.
Yeah, that makes me feel, a little, sorry.
I know it's been one of those things that we've addressed historically. We do need to have a public meeting. We do need to operate this way, and I want to respect what it's like to be discussed. So it's really,
I just didn't want to be rude and pop off, or if I needed to be here to answer questions or anything, but
right.
Eric,
okay.
We could certainly let her introduce herself and explain her interest in being on the committee, and then she could pop off.
Would you be comfortable with that, Courtney? Would that work?
Sure, why not? So, hi, my name is Courtney Olcott. We want to be fancy, Dr. Olcott, but I don't make anyone call me that. I just moved here actually recently, about 2.5 months ago. And I've been working at Indiana University the last 10 years, predominantly working in substance abuse prevention, specifically prescription drug abuse prevention, which then evolved into opioid abuse prevention and harm reduction. I also have a mental health background. And I've worked in mental health promotion as well. I'm interested in being on this committee because I would like to be part of efforts to address SUD and related issues. So trying to keep it short here. So yeah, I would be very honored, but totally understand if it doesn't work out. Okay, so no pressure.
All right. Does anybody have any questions or comments that they'd like to share? All right. Courtney, again,
Okay.
the ball is in your court, we would understand, but I believe we're at the point where, having haven't heard any requests for discussion, I would also entertain any motions to move Courtney Olcott's application forward or to vote on. Sarah, you've got more experience with these recently. Is that about right? Because all we do is have a vote to see whether or not we want to move it on to the Board of Commissioners or not. And they
That's
have the
my
final-
understanding. Rochelle is the Bible, but that's my understanding.
Okay.
That's correct. Just for recommendation to the Board of Commissioners.
I'll make a motion that we recommend Courtney be a member of the LADPC.
We have a motion on the floor. Do we have a second?
I'll second that.
We have a second from Mr. Orr. All right. I think we have to do an actual roll call vote on this though, Rochelle. It's different than the all in favor type of vote. Is that correct?
Probably best. Mhm.
Okay. So if you wouldn't mind.
Jack Adkins. Yes. Eric Geyer,
Yes.
Rosemary Jernigan,
Yes.
Brandon Orr,
Absolutely.
Sarah Smith,
Yes.
and Mary Wallace.
An enthusiastic yes.
Thank you. The motion passed.
Thank you, Rochelle. And I believe we will hear back from Rochelle, or at least from myself and Sarah, regarding the Board of Commissioners' final decision regarding the membership application.
That's right.
All right. Well, I appreciate everybody, and I certainly appreciate our applicant for how quickly that went, because we have a very full agenda today and very excited to have all the folks here to present that we have. We have Jody Ria and Shasta Gish to talk about local methadone clinics here in Jackson County and what that means. And to all of our presenters today, I would simply like to put out that there is, you cannot make this basic enough. You will not insult me. You would actually be doing me a favor by making this as basic as possible, because I think there are some misunderstandings. And so starting at the ground level could be very helpful for all of us to understand what methadone programs are and how they play into our community's health. And with that, I believe we have our local providers. And Shasta, I don't know if, Jody, if you had a chance to meet to talk about how you guys wanted to present.
I know I have a PowerPoint.
I don't have a PowerPoint. I haven't really met with anybody. I got the email to present, just kind of give kind of updates on what we do here and how the program works a little bit. I mean, I can talk about it if you want.
We'll go with the order that we have on paper, and Jody, you were listed first, so.
All right. Well, thank you for having me. I do appreciate it. So I'm the clinic director here at Medford Comprehensive Treatment Center, formerly known as Allied. And we do offer the methadone and Suboxone and Subutex. Right now, we're serving the population a little over 400 patients. We also do have a new medical director. His name is Dr. Williams. He's great. He just started with us. He was a PRN doctor, kind of covered vacation, and now he's full-time with us as of October 1st, so we're excited about that. We also have hired a physician assistant. So right now, we're able to do intakes every Monday, so just one day a week, and it makes it difficult because the need is out there, you know, so that has been a barrier for people to receive the treatment. So once our physician assistant is trained and everything is set, we will be able to do intakes 5 days a week. So we're super excited about that. So the requirement is they do have to have an opioid dependency. They will come in, patients have to come in withdrawal, and they will meet with a counselor. The counselor will do the assessment with them, work up treatment planning, set some goals with them, and then they'll meet with the provider. The doctor then will, recommend what medication will work that would be more beneficial for them on their use, and get those orders in. And then they do come in every day. We get them medicated. We are closed on Sundays. So what we do is we give a take-home So they're able to get their take-home medication for Sunday. And so that way they're still medicated, and then they just come in every day. And they do that for about 90 days. If they have some where their DSAs are coming back without illicit use, they can earn what we call status. And they can then come in, get maybe 2 take-homes, try that for a little bit, see how they do, and then all the way up to coming in just once a month. And we give them every day. They get a takeout for the whole month. We also do the group counseling, and we do the individual sessions. So according to the OARs, patients that enter OTP programs are required to do 9 hours of treatment a month. So Acadia has broken that down to where the patient does 8 groups in a month's time, and then they do a 1-hour session with their counselor. Is there any questions?
I have a question, Jody. I'm Leona O'Keefe, Health Officer at Jackson County Public Health. You mentioned that you'll be going to the ability to do intakes 5 days a week, but I missed when that's happening and how you're able to do that. Could you share a little more?
Sure. So we just recently hired a physician assistant. And so, we've got to wait for the licensing and obtain the waivers and the permission through the state and the feds and SAMHSA and all of that. Once that's all said and done, then we'll be able to move to 5 days a week. So I don't have an actual time frame on that. I'm hoping that it's soon, relatively within the next few weeks, I'm hoping. But right now we are doing the intakes where because they do have to see a physician or a physician assistant in person day of intake. So right now we have our medical director in here on Mondays because he is from out of state.
Thank you, Jody. I appreciate that. And let's see. And Shasta, maybe we could have you present as well. And if folks have other questions more specifically for our OTP programs, that would be great. So Shasta, the floor is yours.
Thank you. So I do a PowerPoint for my orientation group. And so this is a shortened version of that, what I do. I also have another PowerPoint that I do for community partners that's a little longer, but I shortened it up for you guys today to make it about 15 minutes. So what is medicated assisted treatment, or MAT? It is an FDA approved medication. It's a whole person approach to treatment. So for the sake of this group, we will be discussing MAT for opiate use disorder. So addiction is a chronic disease and there is no cure. Clients will have to manage their symptoms long-term. Long-term opiate use damages the part of the brain that is responsible for motivation, organization, bonding with others, and rewards. MAT stabilizes the brain and it does control cravings so the clients can do the work of recovery, because it's kind of really hard to engage in recovery activities or counseling when you're having extreme craving or in withdrawal. So why is it beneficial for people with opiate use disorder to take medications? Without MAT, clients with opiate use disorder are at higher risk for relapsing and possibly overdosing. MAT reduces the chance of relapse. By quitting the use of illicit opiates, clients are less likely to be arrested, contract HIV and hepatitis C by sharing or using dirty needles, and they also have a longer life expectancy. So that's the harm reduction piece of MAT, which I think is really cool to think about. So what medications are approved for MAT at Medford Treatment Center? We do buprenorphine and methadone. So buprenorphine is Suboxone or Subutex. So how does medication-assisted treatment work? MAT does stabilize the brain by breaking the cycle of craving and withdrawal. MAT allows clients to fully benefit from counseling and peer support services. MAT medications are meant to stabilize brain chemistry that drives motivation, bonding with others, and it also blocks the feel-good effects of opioids. So if clients are on a therapeutic dose, they're not supposed to be able to, feel the feelings of getting high anymore. Addiction is a chronic disease, and MAT helps to decrease the risk of relapse and help prevent relapses from resulting in overdosing or death. Starting out on methadone or Suboxone, a client's dose may need to be adjusted regularly. If a client wants to adjust their dose when they're in the dosing booth with the nurse, they just ask for a dose increase. Once a client is at a stable dose, clients can stay at this level for as long as they need. Some people do stay on it for life, and some taper and switch to other medications. Length of treatment varies from client to client. It's not a contest, and MAT is not a short-term solution for most people. According to the National Institute on Drug Abuse, the length of methadone treatment should be a minimum of 12 months, although some clients do benefit from longer-term maintenance programs. All right, so this is a question that I'm always asked. I remember the first time I was asked this question, I didn't really know how to answer it, so I did my research. So the similarities between methadone and Suboxone. Both medications do contain a synthetic opioid, methadone or buprenorphine. Both of them can ease withdrawal symptoms by stimulating the brain's opioid receptors. Both can carry the risk of misusing it, but it's far less common with other opioids, and it's usually used for therapeutic purposes. Both can increase the likelihood of achieving treatment goals. Both medications are prescription only, except you can only get methadone through opiate treatment program like Medford Treatment Center. Both of the medications are safe for long-term use and more effective when a person does take them for long durations. All right, now here's some differences between methadone and Suboxone. Methadone is the name of both the drug and the active ingredient. Suboxone contains two ingredients, buprenorphine and naloxone. Methadone is a full opioid agonist, while buprenorphine is a partial opioid agonist with the ceiling effect, meaning the risk of overdose is less with Suboxone compared with methadone. And what the ceiling effect means is, let's say somebody is like on 50 milligrams of methadone and one day they take 150 milligrams of methadone, they're likely going to overdose. But if somebody is, let's say, on like 12 milligrams of Suboxone, if they take 24 milligrams or more, they're not going to overdose. While doctors can give either medication during pregnancy, they may prefer buprenorphine-containing medications over methadone due to the ceiling effect, lessening the risk of neonatal abstinence syndrome. The dosing for methadone is much higher than of Suboxone, and the rate in which the doses are increased also varies between the two medications. Clients are expected to engage in treatment. We want them to meet with their counselor at least for 1 hour a month, a minimum, and at least one group a month, unless their treatment plan indicates otherwise. We want clients to be respectful of staff and other clients, follow staff direction, dress appropriately. We don't want them discussing their care or the care of others. We want them to refrain from using any disrespectful language, aggressive behaviors. They're not allowed to bring weapons on their premises. We want clients to refrain from being under the influence of drugs or alcohol. We don't want them to litter. We don't want them to loiter within 1 block radius of the clinic, because we do have neighbors and we want to be really good neighbors. Clients are only to be on the premises to receive care, and then they're supposed to leave immediately afterwards. They can't possess, use, sell, or solicit drugs, or bring any paraphernalia onto the clinic property unless it's their lockbox. We expect clients not to divert any medications and only to bring registered service animals. I know as a staff, like all the counselors are really here for a reason, and we really want to help our guys through counseling. And so we help clients better understand MAT, learn relapse prevention, reduce anxiety, stress, increase self-esteem and self-confidence. We can also assist them with financial issues. If they want to get a job, we can help them find employment, housing, healthcare needs. So I think we all work pretty hard at meeting the clients where they're at and assessing their needs and trying to meet those needs and connecting them with resources. Due to COVID-19, we do offer telehealth or phone counseling sessions, and we also do group counseling. So clients can start earning take-home status. And so every 90 days, we're assessing them for compliance. And so every 90 days, we're assessing if they're employed or if they're on disability or a homemaker, that they've remained absent of criminal activity, that they've had have a stable home life, adequate time in treatment. They have a lockbox. They display appropriate clinic behavior. that they provide the treatment center with all the list of medications. Their take-home medication contract has been signed. They're in financial compliance if they're self-pay. And then the most important one to earn take-home status is that they have to provide at least 3 consecutive illicit free substances. So we are open Monday through Saturday. At 6 a.m. is when we start doing intakes. And Tuesday is when they see the doctor, and that is scheduled. Our medication hours are Monday through Friday, 5:30 to 9:30. We are closed on Sunday, and clients get a take home for Sunday. And then counseling is scheduled. And then we also have sister clinics in Bend, Grants Pass, Pendleton, Springfield, Tri-Cities, and Spokane. So, is there any questions?
Shasta, I have a question.
Yeah.
So people who are looking for intake, do they walk in on Monday and then they get scheduled on Tuesday?
That's a great question. So if clients want to intake, they can either call us and do a pre-screen, or they can walk in and do a pre-screen. And then after that, our intake coordinator calls them and tells them about the intake process.
Shasta, just as a follow-up to that, or Jody, just in terms of a given week, about how many people do we have showing up to your clinic saying, hey, I'd really like to look at methadone as something to help me, work through some of these addiction or some of the issues I have regarding an opioid use disorder?
Like showing up for a pre-screen or showing up to ask for help?
I'll take either.
Okay, I would say average a week, 5 to 15 people.
Is that
That's
adequate?
about how it is here.
Okay.
Yeah.
And we have enough capacity for the needs that are presented by the people that are in our community?
Yeah, I think we have enough space for sure.
I do too.
We
do
were
too
out a
here.
doctor for a while, and so now we are. We just hired a new nurse practitioner, and so that means we will be seeing people once a week. It was like every 2 weeks for a while, so now we can start seeing people weekly.
Yeah, that's about how it is here at this clinic too. I mean, it's definitely, we have the space, and we have anywhere from about 5 to 15 intakes coming in weekly.
I don't want to monopolize the questions, but I do have a few. So my other one is this. I think when I started working with people who were often suffering from substance use disorder and methadone would get brought up, I would be very judgmental. And I say this about 10 years ago, and I would be almost dismissive, like, oh boy, is that really getting healthy? Is that really a pathway to a different life? And I think that I was not fully aware of what was happening. And then one day I was in Starbucks, because I'm always in Starbucks. And this young guy who I'd worked with a long time, and he'd had a tough go of it. I see him and he's at Starbucks. It's fairly early in the morning. I'm like, it's so good to see you. You're doing great. And he goes, yeah, I have my life back. He goes, I'm in my kid's life. He's wearing work boots. He's like, I'm part of this crew over here. And I go, I'm just so happy to see that. And he goes, that you found something that works. And he kind of bowed his head a little, like he was a little bit ashamed. He goes, yeah, I'm working methadone. And it hit me that I had created an environment where this person who was working a job where you have to get up in the morning, who looked healthy, who was seeing his kids, felt somehow like he was less than because his program was not the one that gets constantly brought up as being, the ideal. For him, it was the ideal. And for me as a community member, it was great to see. And so that is a testament to the work that both of your clinics do. And that was one of those moments where I started to think differently about the people who were utilizing methadone as their pathway to get healthy. Are there other things that you guys are trying to educate the community about when it comes to like stigma and attitude regarding this kind of work?
I know I talk about it because I used to feel the same way as you. I came from an abstinence-based program. That's like how I got clean. So that was like the only way that you could get clean. But I started going to college, and then I started working more in the field. And like your story, I started seeing clients like having jobs, parenting their kids, not going to jail. And I'm like, okay, so maybe this MAT thing is working. And so I like to tell my clients, you're clean. Look at your progress. You're working so hard. I still encourage you to go to the 12-step because people are scared about identifying themselves being on MAT. And it's like, well, people aren't talking about being on insulin, so you don't need to talk about what medication you're on. And so I really think it's just important to empower them and to let them know that they are clean and they're doing what they're supposed to do. And some people need medication, and abstinence isn't the only way.
I agree. I mean, that's really what it boils down to, is they've got to work on their confidence, and that's what they do when they're in this program as well. You know, and it does start like being honest here, being honest with primary health, talk to their other doctors, letting them know this is what's working, and, you know, be proud of where they've come to, you know, and where they're at in their recovery. It's a big piece of it, you know, but it is hard. That stigma is still out there, and you know, we can just make sure that when they come here, they feel safe, and we encourage them to be proud of where they're coming. Don't be ashamed of it, because it's like a diabetic being refused insulin, or, you know, being ashamed that they have to take insulin. So some people just need a little extra help.
Thank you both. Any other questions for Shasta or for Jody?
I have a couple of questions. One of them is, do you utilize Sublocade in your practices there? And do you utilize peers?
We don't do Sublocade, and we don't have a peer support. We do have a certified recovery mentor, though, that we do utilize.
And we do not do Sublocade here either, nor do we have the peer support as well.
And Sarah, I'm going to take a risk, but Sublocade is the once a month dosage of.
Yeah.
Yes. Okay. Well, Jody and Shasta, thank you so much for being willing to present about what our OTPs do here in our county, and what the benefit and what the impact is, because I think that we truly are saving lives through those programs, and thank you for the work that you're doing.
Thanks for having me.
Yeah,
Thank you for having me. I really do appreciate it.
thank you.
I do have one more question for Shasta.
Oh, we do have one more question. Great.
Okay.
Shasta, are there any plans for expanding your intakes beyond Monday and Tuesday?
I don't know of any right now, but I'm sure the more people who need MAT, that's probably a conversation that upper management is having about expanding those hours. But I don't know for sure.
Okay, because I work at Rogue Regional Medical Center. I'm one of the social workers here at Rogue Regional, and I know one of the challenges we've had with discharging patients is access, is getting timely access to methadone treatment. We've often had to hold patients here for extended periods of time because we haven't been able to get them access relatively quickly. So that's been a big barrier for us. So that was the motivation for that question.
And I just want to chime in. This is Kyle. I'm the program director at Medford Treatment Center, and we do have goals and plans to extend our admits. Of course, that it really depends on finding providers who are willing to contract with us and come on board and prescribe. So we're always open if anybody has any, providers or referrals that want to join us and help us expand that.
All right. Well, thank you all very much for your presentations and for just making us aware of how these services look. Our next speaker is Dr. Mann from the county here, and he's going to talk about methadone pathways and bridge efforts in this presentation. And Dr. Mann, I shouldn't do this, but if there's any way you can talk about the way that fentanyl has impacted the need or the results we're getting from the use of methadone in our community, I would love to hear about that, just because fentanyl, I think, is really on a lot of our minds in terms of how it's impacted us.
Well, you're in luck, because that's mostly what I prepared to talk about, because that's really what's different, than the last time you and I talked about this. And I just want to start off and say thanks to Shasta and Jody and everyone at your organizations for all the work you do. Our opioid treatment programs really are in some ways the unsung heroes. You do such good work, and for a long time, really, there was a lot of stigma. And I just want to say thanks for the work that you do. So yeah, we're here. Let's talk a little bit about what's different now. We have fentanyl in our community now. We've been talking about this for years. It would happen at some point. It didn't seem real, and then all of a sudden it was here, right? So fentanyl it's often a non-pharmaceutical version of fentanyl. Fentanyl was originally designed for use in the pharmaceutical industry as a better, really rapid-acting opioid for use for pain management. It's more what we call lipophilic, so it crosses the blood-brain barrier faster. Great for use for when we need it, but as a drug of abuse, it's been very destructive in our community. We're seeing it a lot, right, in pressed pills, often labeled as things other than fentanyl, obviously, right? So, as Percocets or even Xanax, medications that aren't even opioids, And we're seeing it in a little bit of everything often. Why did this happen? Because the people selling drugs can make more money selling fentanyl than they could selling black tar heroin, which was the prior kind of version of the street opioid that was most common here, right? So fentanyl really binds onto the opioid receptor, the mu opioid receptor, really strongly. And well, it activates it in even a slightly different way than some other opioids. It just is it's really good at it. And so it makes this whole thing difficult. You know, the medications we've had in the past to treat opioid use disorder, 3 FDA approved options, right? Extended release naltrexone, buprenorphine formulations, and methadone. Because of some historical reasons, legal reasons, right? We have those available in different settings. So we heard from Jody and Shasta about our opioid treatment programs. That's currently the only outpatient setting you can get methadone for opioid use disorder. Now, you know, any primary care physician or pain medicine physician can prescribe methadone pills for pain, but because of the Harrison Narcotic Act, we can't prescribe methadone for opioid use disorder. We can't prescribe any controlled substance for opioid use disorder without a specific FDA indication and special dispensation to do so. You've heard of the data waiver. That's the Drug Addiction Treatment Act of 2000, and that is a waiver of the Harrison Narcotic Act that allows us to prescribe buprenorphine in the outpatient setting using the FDA approved formulations of it to do so, and not even the non-FDA. So there's also some formulations of buprenorphine for pain, and we can't even prescribe those for opioid use disorder without in the outpatient setting without running afoul of these regulations. So if it seems complex, it is, and there's legal and historical and reasons, and you know, of course, the common thread through a lot of that is historical stigma against treatment of substance use disorders in medical settings. So you know, why are we talking about this now? What makes fentanyl different? Well, you know, one of our major strategies in the past of outpatient treatment was to use buprenorphine for the treatment of opioid use disorder. And it's, you know, always been kind of tricky, you know, to get people onto buprenorphine from use of opioids. But with fentanyl, it's even trickier, and people are having a lot of difficulty in the outpatient setting. So we're looking at different options: low dose inductions, high dose inductions, and thinking about other ways to get it started. You may have seen an article recently where paramedics in Camden, New Jersey are starting buprenorphine in the field following opioid overdose. I don't think it's a bad idea to help with treatment engagement, to help people get through to other portions of care. There are studies. We'll talk a little bit about one program in California that's getting people started on pretty high doses of buprenorphine in the ER. There have been some studies John Mariani has done looking at getting people started on long-acting extended release buprenorphine, the subcutaneous buprenorphine that lasts a month. We talked about that earlier, you know, on the first day in the ER and going from there. So there's a lot going on. I would say it's still early days, even though there's been fentanyl on the East Coast for, you know, years. It's been difficult to manage, and we're still trying to figure out how to do this. And I think methadone can be, and opioid treatment programs can be a big partner because in general, that's a lot easier. So we really just have to be pretty individualized about how we go through this. You know, if you look around the state at what other people are doing, OHSU Impact, that's their inpatient addiction consult team. You know, they're looking at thinking, they've done a lot of when we have people in the hospital for other reasons and they're starting to go into opioid withdrawal, we need to treat it to help them stay for their medical conditions. Otherwise, people get very anxious and agitated. They go in withdrawal and they often leave against medical advice. So they've had, in the age of fentanyl, they've really started to tailor their treatment. A lot of what they're doing is a rapid methadone induction. You are allowed to use methadone in the hospital without being an opioid treatment program to treat opioid withdrawal, as opposed to the outpatient setting. And then often getting them from methadone, you know, quickly 4 days or 7 days, and transitioning to buprenorphine using what we would call a low dose induction, starting with very low doses of buprenorphine and slowly ramping up the dose while they're still on the methadone. And then by the time of discharge, you can stop the methadone once they're up to a therapeutic dose of the buprenorphine. There's also the Oregon Society of Addiction Medicine, or ORSAM. This is a big enough problem that we're having monthly meetings around the state to talk about, how are you handling this? How are you doing it? It has proven very difficult in the outpatient setting, in settings where you don't have access to methadone, to get the kind of treatment retention that you want to see with outpatient-based opioid treatment. So lots of people are being lost to follow-up and leaving early on. It's very difficult to tolerate the transition from fentanyl to buprenorphine. It can be done with a lot of adjunct medications, but it is pretty difficult.
So Dr. Mann,
yeah.
just prior to our fentanyl explosion, if a person came in and said, "Hey, I'm addicted to heroin," they would come into an outpatient setting. They would work with a provider. They'd be given a prescription potentially for buprenorphine, and they would be able to generally make that transition. Or how would that work? How did that look compared to how
it's always been difficult? And I have some slides coming up here. I'll talk a little bit about opioid withdrawal and the risk of precipitated withdrawal and why it's difficult.
Okay.
Really, I'm just kind of going through some of, just to kind of give you a scope of the problem and impression that this is something that's difficult for everybody right now. So people are using a lot of different strategies. Sometimes it's very low doses, sometimes it's very high doses. We would never used to see 32 milligrams of buprenorphine used in this way in the past, and we're having to use very high doses sometimes. One thing that does come up is that it doesn't seem to be more difficult to get people onto methadone necessarily than from fentanyl. But that's the general consensus in the ORSAM forum, but it really has been difficult to get onto buprenorphine in the outpatient setting. So we just got to approach this with a little bit of understanding. We don't have all the answers right now, and this is more difficult. And let's perhaps take time to think about what are some ways we can work together as a community, all of us together as a treatment system to help make this work for patients, for clients, for community members, for citizens that we're here to help. So this is not an electron microscope representation of what an opioid receptor looks like. This is just a cartoon, but hopefully it is helpful in some way. We can think about this being an empty opioid receptor here at some point. This is perhaps representing an opioid such as fentanyl, morphine, heroin, and this is perhaps looking like buprenorphine. Once again, not drawn to scale in any way, just something to think through this. So when people have been taking an opioid, we develop what's called allostasis. Our body gets used to having that other substance in there and changes our physiology a little bit to where we expect it and need it, or we're very uncomfortable. So an opioid might click right in that receptor and provide some relief. That's kind of fits in there good. This is the slide we used to use kind of before the era of fentanyl. And now, because of the way fentanyl conforms with the mu-opioid receptor, the subunits of the receptor maybe even like it a little bit better. It maybe even works a little bit better. And I'll talk a little bit more about that in a moment. Buprenorphine doesn't fit in there quite as good, but it blocks the other opioids that might be in the area. And in that way, it's a blocker. It's got higher affinity, probably about 6 times higher affinity for the mu-opioid receptor than fentanyl even. But it doesn't activate the receptor. And so that's when I think it was Shasta was talking about how it's a little bit safer. There's a ceiling effect that's safer in overdose. That's kind of what we're talking about there. And then it dissipates kind of coming on and off. So, on the left hand of this graph here, you might have the activity of the receptor. How, that's when we talk about the ceiling effect. You can see buprenorphine, really, it's what we call a partial agonist. It really only activates the receptor partially, but it does block it well. So that's what we talk about being a partial agonist. full agonists there, an example would be methadone. And fentanyl, maybe even we could think of it, right? There's no such thing as more than 100%. We could think of it as even a little bit higher than that, perhaps even the way it activates the receptor. And so when we think about opioid withdrawal symptoms that we'll talk more about on the next slide here, what made it difficult to get, what makes it difficult to get started on buprenorphine in the outpatient setting really would be the transition then, from this, from expecting a full agonist. So if you come in and you still have heroin or fentanyl in your system, and you were to get a medication like buprenorphine that it binds very tightly to a receptor, but it doesn't activate it as much, right? Then you're going to have a rapid decrease in activation there at the receptor. So it's going to kick everything off, kick off the heroin, kick off the fentanyl. And buprenorphine is going to bind really tightly, but not activate it very well. And so you're going to go into what we call precipitated withdrawal. You're going to have withdrawal symptoms. And so the way to get around that, right, is so everyone knows you need to come in some withdrawal, right? So it used to be, we'd say, 12 to 24 hours since your last use. Because fentanyl is a little bit different, it's so lipophilic, it crosses the blood-brain barrier quickly and then redistributes into the peripheral tissues, your fat tissues. Right, we're used to thinking through this with cannabis, probably how it's so long acting, how it goes into your fat tissues and then slowly comes back out. And so the drug screens can be positive for a long time. It's kind of like that, not that long, like with cannabis, THC. So if you use fentanyl once, it's really rapid acting and then comes off really quickly as well. If you're using it all the time, as in the case of, chronic use and illicit use, you really get this redistribution to your fatty tissues, and then it slowly comes back out and goes into your brain. And that makes it a little bit longer acting and makes it harder to get on to a medication like buprenorphine, because someone has to wait longer, be in withdrawal longer before starting buprenorphine, or you risk precipitated withdrawal. And that's part of why it's so difficult to get started, and has been more difficult to get started in the outpatient setting. Opioid withdrawals, we all know, tachycardia, nasal stuffiness, running, tears, pain. You see what we call pylor erection, right, or goose flesh, some people might call it, and that's where we get the term cold turkey, to go cold turkey, right? Your skin looks like that. Sweating, chills, anxiety, irritability, pain, GI symptoms, right? Diarrhea. So looking back, this was from an article published in the New England Journal of Medicine back in 2000. The year 2000 is familiar, right? Because the data 2000, that's when we got the Drug Addiction Treatment Act that legalized the use of buprenorphine in the outpatient setting. Looking at, does buprenorphine work as well as methadone? Probably works better than low-dose methadone. Low-dose methadone, we don't even really think about it. I took the slide out that talks about what that even means, but high-dose methadone really is kind of just typical dose now, like 100, 110 milligrams, and even more now in the age of fentanyl. But looking at buprenorphine versus methadone for treatment retention probably worked a little bit better even. But this was part of the studies looking at, is buprenorphine a good option for outpatient treatment? It works pretty well, especially if it's something that, primary care providers can prescribe, as opposed to having to go to a specialized treatment setting. I'm going to skip through this a little bit. Basically, in the fentanyl era, we're having to use higher doses of buprenorphine than we used to have to use. Used to think that on the first day of an induction of getting someone started, you kind of would max out at 8 to 12 milligrams. And now we might be using 24 milligrams, so higher, and then higher, kind of initial stabilization doses, used to be 24, used to be real to max, and now some people are using 32, having to use up to 40. So we call that like a high dose induction to get someone stabilized to the point where they can tolerate withdrawal and getting on to medication and getting engaged in treatment. Also, here's a slide on, Sarah had asked about the long-acting injectable buprenorphine. I think it's a great option. I think availability is still a little bit limited. It's expensive. One of the great things, there's a lot of great things about it. I think it's hopefully we get a lot more availability in the community in terms of access all around in this area. And one of the reasons it maybe works better is this, when you think about the plasma levels of someone taking the 300 milligram dose kind of consistently, which is kind of what people are doing now instead of going down to the 100 milligrams a month. If someone hasn't quite stabilized, you know, if you're at the 300 milligram dose for a month, it's kind of like being at a really high dose of buprenorphine in the outpatient setting, like maybe 40 milligrams or more. And for some people, that's what they appear to need when they're in early recovery from fentanyl. So just want to thank everyone around the state who has, you know, really contributed to us understanding this. And when we think about bridges, you know, the way I would, how do we get out of this setting? You know, I think that you might have heard me say before, I really would think that 24/7 access to treatment on demand probably is one of our ways out of that. And that would be in this setting, you know, if we had much greater access to opioid treatment programs to help people get started onto buprenorphine and then potentially bridge to, get started on methadone and then potentially bridge to buprenorphine for continued treatment in the outpatient setting, and kind of mirroring the success that we have seen on the inpatient side, you know, and helping people get engaged in treatment, because it's difficult to tolerate, and certainly there's a lot of need out there, and we need to think about, you know, how do we do this as a community. So going back to the original, you mentioned bridges. What are ways to do that? You know, in the hospital setting, often they're using methadone for early stabilization, then low dose induction to buprenorphine, and then stabilization and discharge right at that level. We could think about that in the outpatient setting as well, using OTP type structures for the time being when the law is the same. There is a lot of talk, even in Oregon, about, you know, how do we get access to prescribing methadone for opioid use disorder outside of OTPs in the outpatient setting. Certainly it's not quite as safe a medication, and there needs to be guardrails around it, but the scope of the problem is huge right now. But one way to do it without changing laws would be increased cooperation with OTPs, getting people started in OTPs, transitioning to buprenorphine, maybe using a low dose protocol, and then continuation in the outpatient setting. Probably lots of use of the long-acting injectable buprenorphine. I love the idea. Stacy sent me an article earlier. It's one that was in the Lund Report yesterday. You know, of pre-hospital care, paramedics, EMTs, helping people get started following overdose. So responding to an overdose, administering naloxone, right, which reverses the overdose. And then the problem there is people are then in severe withdrawal often go to find opioids to use, and it's hard to get them even to the hospital sometimes. And so what's being proposed is administering higher dose buprenorphine, or even they're in the field, getting them to the hospital, perhaps even getting them on long-acting injectable buprenorphine in the hospital, you know, on day one, and then transition to community care. These are all kind of, I used to think they sounded far out there. I don't think so anymore, just based on the scope of the problem.
Dr. Mann, you mentioned 24/7 treatment on demand. For
Yeah.
you, that means access, or for when people say, when we hear that term brought up, I won't just, because it's not specific only to you, that generally means adequate access to medicated assisted treatment, usually in the form of methadone? Or what were you thinking with that term? I want to make sure that I understand it correctly.
I mean, you know, you could think of 24/7 access to Diet Coke, but I mean, specifically, I think when we talked about this, it's to treatment, and then, you know, what do you have? And ideally you'd have availability to both things. I think right now in the age of fentanyl, you know, what we would really need, I think, would be access to effective detox, helping someone getting started in treatment. And so then we think, well, what is that in this age of fentanyl? And probably if it needs to be acute, it probably should be stabilization with methadone. But I think any scenario, any treatment setting where you have access to methadone, you can have access to buprenorphine. And so then we have treatment, you know, patient choice, which I think is always important. So if it's 24/7 access to just buprenorphine, sure, that's better than what we have now. If it's 24/7 access to buprenorphine or methadone and psychosocial support, that's even better. So does that have to happen exactly the way it's being done now? No. Is it happening very many places? No, it's not. And it's probably largely economics. It's expensive to run anything 24/7. It's expensive to have access to medical providers in the middle of the night. That it's expensive to have medical providers who want to do this work during the day. To have them during the middle of the night would be hard as well. But if we're going to think theoretically about how to get out of this, I guess here's what I always come back to, probably to get out of this problem that we have, where people have 24/7 access to fentanyl. We have to have at least as good access to treatment as people do to fentanyl, I think, probably.
Thank you for clarifying that. I think that's a really important way to look at it. Any questions for Dr. Mann? Other questions? All right. Well, Dr. Mann, thank you again for, updating us, and hopefully we won't need to update yet again as drugs of abuse change in our community. But I appreciate not just the knowledge, but also the fact that, you've been looking, and you speak of the idea that to get out of this epidemic and out of this crisis that we're facing. And I think that's hopeful on many levels.
I don't think that we should think of this as a transient condition without very dramatic change on our part in treatment. This is not in our community, we used to see kind of fentanyl spikes here and there when fentanyl would be contaminating our primarily black tar heroin supply. And this is not what that is. This is a wholesale shift, and it's not going anywhere as long as cartels are making money at it. And so we're in this for the long haul. We need to be thinking about solutions to adapt to where we're at now.
Thank you. All right. And Dr. O'Keefe is our next guest with her team to talk about community-wide methadone challenge and to facilitate a discussion. And so, Dr. O'Keefe, I'd like to turn that over to you and your team as you look to present to this group.
Thanks, Eric. First, I have Dr. Barb Villano with me here. She's an emergency department physician, a background in public health, and is here kind of observing things today. And we also have Dr. Danielle Holt. She's an emergency department physician at Asante, and Melissa McGuire. She leads the social work team at Asante. So I'm going to start by describing hospital-based opioid therapy, which Dr. Mann mentioned briefly that OHSU has a program called IMPACT, and that was really the first HBOT program, hospital-based opioid treatment. And Dr. Honore Englander has led that, and they've had tremendous success and have distributed grants to hospitals throughout the country to replicate the program. And fortunately, in our region, both Asante and Providence received grants for that. So both of our hospital systems are working on getting this up and running. And really the crux of the program is, say someone comes into the hospital for appendicitis and they have a prolonged stay, and it turns out they have a substance use disorder, or more specifically an opioid use disorder. We want to be able to offer those individuals treatment and support and care, and not only in the hospital, but also when they transition out of the hospital when they're discharged. So the program does a lot of work to help educate the medical team in the hospitals, but then there's a specific team that comes around that patient. So it's a physician, usually a social worker, a peer. So you're hitting all of those components of the care that someone might need. And if they're interested in treatment for their opioid use disorder, it can be started while they're in the hospital. And they can already start learning about the support systems that are available. And then that team would help connect them to treatment at discharge. And meanwhile, their regular medical team is continuing to care for the appendicitis or whatever else is going on. So we have our couple guests from Asante here to kind of dive into that a little bit more with us, because one of the things that they're running into, which Melissa spoke to a bit, is if someone is started on methadone in the hospital, they can be prescribed the methadone there, but they can't be prescribed methadone to continue at discharge. They have to have that intake appointment at one of our methadone clinics. And that can be a challenge if intakes are only occurring once a week. That's why I was really excited to hear that from you, Jody, that you may be going to 5 days a week in the next couple of months. And so that may really relieve some of that pressure for the patients who are appropriate for methadone. So that's just kind of setting the stage. I would like to give space for Melissa and Dr. Holtz to chime in if there are other things that you want to add into this.
I just wanted to add, I think Dr. Jaju just joined as well. She's one of the hospitalists at Asante.
Great. Welcome, Dr. Jaju. Glad you're here.
Thank you. Sorry for being.
No, it was perfect timing. And I forgot to mention, you know, at Asante, kind of the champion for this is Dr. Erin Brender, and she's really been partnering with Dr. Carrie Hecox, who I think many of you are familiar with at Oasis. So they've really been leading the charge on this. But we're glad to have our other Asante folks here to chime in. So do you guys have anything to add to that description of the hospital-based program or the challenges that you're facing around methadone in particular?
No, I think you summarized it well. I know, you know, from the social work perspective, you know, the social workers typically are the ones involved in coordinating peer mentors, doing our best to link people up with the intakes and the outpatient treatment. So I think from the social work perspective, having access, you know, as many people have mentioned in this conference, in this workshop today, that having that access more readily available is going to be a huge component in terms of breaking the log jam that we often experience here.
I had a question actually for Shasta. You mentioned that people have a pre-screening and then an intake. If someone walks in on a Monday requesting a pre-screening, do they get an intake the same day?
It's happened like that before. Is it going to happen like that every time? I don't know. We might not have enough counselors to assess them, but it has happened like that before.
Okay. But that's not the norm per se?
Per se, no.
Well, and again, this is Kyle, the program director at Medford Treatment Center. Something I want to interject, and I think it's been part of our struggles, is that we talk about, you know, intakes 5 days a week, and I think some of the problems lie in that when we talk about intaking one client for the things that we have to do a pre-screen. We got to have a doctor readily available to prescribe the medication. We have to have nurses available to dispense the medication. We got to have counselors available to do an assessment on a client. So the amount of things that come into one intake, it's a very in-depth process. And methadone has to be prescribed on a face-to-face appointment with a doctor. So there is so much that goes into intaking one client that staffing and the current climate that we deal with, it's very, very difficult.
I too would like to chime in. I'm Lainey from Medford. I'm one of the nurses. The only other problem with admitting clients who are already on methadone at the hospital, say they're on 60 milligrams at the hospital, and then they're intaking with us, the state only allows us to start clients at 30 milligrams. And so in order for them to come in and start at that higher dose, we would have to put in a state exception through the state. It's a paperwork we fill out, and that can take a couple days. So that's also something to think about when trying to get people in with us at higher doses of methadone.
Oh, wow. Lainey, I was not aware of that. That's a huge barrier.
Yeah. We've had a couple people who have, they've been in like a rehab facility. They were on like pretty high doses, and we coordinated and made it happen, but it does take a lot of work on both sides. So that's just absolutely something to keep in mind.
Yeah. Is that a state level regulation, or is that coming from the federal level?
That's a Kyle question.
I'd have to get back to you guys, and then I don't know if it's state or federal.
What if someone transfers between the two OTPs? Say someone is at one OTP on 100 milligrams and they transfer to the other one, does that rule still hold true? You can.
It does not. That's completely acceptable.
Yeah. Okay, so it's only when they're a new. So
Yeah,
even if the
and
hospital.
I think as I'm discussing this and some of the barriers that we face, I think that with the new climate of fentanyl, I think that on the state and federal level, that some of the rules and exceptions that have been in place for a long time, I think that's where we could really start to see some improvements in these areas, is if we can start to make those changes on a larger scale to free up the OTPs to maybe incorporate telehealth to get people in, because it's much easier to get a provider, to do a telehealth session than it is to get somebody on site for, multiple hours.
Kyle, would you be willing to email me after this when you know what level that decision is coming from? Because that sounds like the kind of thing that we can advocate about and maybe really see some tangible change.
Absolutely.
I'll put my email in the chat for you.
Thank you.
Kyle and Lainey, I want to thank you both for adding, for sharing that information. I think certainly from my perspective, it's very helpful to have a better understanding of the different layers and the complexity and the different components. That it's not just it's not as simple as it might seem from an outsider's perspective. Along those lines, I do have another question for Shasta, Kyle. If we are looking at discharging a patient from the hospital, we are looking at kind of trying to target a certain time frame. Would there be any benefit to us reaching out to your organizations directly, trying to plan that with you all and coordinate ahead of time and having all those supports available on the day of the patient's discharge if we're wanting to, or, with whatever time frame we're needing to get them in and to be seen?
Yes, absolutely. I mean, one of the things that we really try to do is, working with community partners or people that are coming from a controlled environment. If we can coordinate getting somebody in to where we can have a warm handoff from, say, a hospital to our facility or the jail to our facility. I mean, that's what we strive to do. We strive to work with people, to bridge that gap to where people aren't sent out from the hospital or from jail to the streets, because we know what that equals. And, oftentimes if it becomes even increasingly dangerous, for those situations. So yes, we are absolutely willing to coordinate and schedule and do anything that we can to bridge that gap.
So if you two could share maybe in the chat who the best folks to contact would be, at your organizations, that would be enormously helpful.
I'll put it in the chat right now.
Thank you.
I think that would also open the lines of communication for other things like our OTPs knowing what kind of demand is out there and whether it's worthwhile to pursue adding in more intake appointments through the week. And I realized I had intended to say, and I forgot to, this is not just a methadone problem, right? We have an access issue across the board for all forms of treatment. So I don't mean this at all to feel like we're picking on methadone clinics. This is everywhere. And we know Oregon is really hurting in this way. But for this particular conversation, we just were focusing on methadone. So didn't want to make you guys feel like you're getting picked on.
They don't seem picked on as an outsider. They seem like they're the most popular kid in school and everybody wants to hang out. So if we can get action.
Well, and the hard part for us is that, anybody who jumps into this industry, I mean, we want to reach out and help everybody and anybody we can. So, I mean, we don't feel picked on. We just feel like, we would love to do more, and I think everybody on this meeting feels the same way.
Well, not to mention, it sounds like you all are dealing with many more restrictions than some of the other forms of medication, of MAT. So it's certainly not something you all have got control over.
I wanted to ask specifically about after hours and weekend issues. As an emergency physician, I see a lot of these patients coming to me at hours when I don't have a social worker available and I can't contact your clinic directly. So I'm wondering what is the best pathway when I would like to refer a patient and it's 2 a.m. on a Saturday.
I just added in the chat, we have an on-call phone that's with one of either our clinical advisor, nursing supervisor, or myself that we have at all times. I mean, at 2 a.m. would we be able to answer? Maybe not, but we'd be able to respond quicker than we would if not. But like I said, I just added our on-call number onto the chat.
Kyle, I don't see anything coming through on the chat. I'm not sure if it's going to one individual instead of to everyone. Sometimes that happens to me.
I think I'm just directly emailing Eric or messaging Eric.
This is Darren from JCC. I really appreciate this conversation. It's great. It's timely for us, at least. I'm thinking about that question from you, Danielle, about outside of our hours, overnights, weekends, when we don't have the offices open. And I'm just curious for the folks that have outreach teams in the field. I know we're working on that 24/7 response with some of our peer groups, but just providing a warm hand, like a happy medium, to me has always been able to have a trusted peer or someone that they could refer to during those times that could, help with that handoff to the clinic. I know that some of this is never perfect, but just adding those tools to the toolbox. So I don't know if those have been considered, but just like peers responding to the ED to support the ED staff and making those warm handoffs. Is that happening, or does that strike a chord with anybody?
I think that's in process, and that's certainly part of the burn process and being able to respond. But I think, like everyone else, the ability to hire all those folks gets in the way of that. So I think there will be more to come on that. And that certainly is the hope and the vision for some of those providers that are getting those dollars.
Yeah, this is Nathan Olson at Addictions Recovery Center. Thanks, Sarah, for bringing that up. We do have a couple of CRMs that are peers that are working as on a swing shift right now. We're still working on filling our graveyard shift positions, but I can put the number in for our community response team. And those are the peers and the certified recovery mentors that are responding to the hospitals and the EDs and primary care clinics after hours as well.
And I would posit if we were to go that route, like to do some work with the medical teams and like your team, Danielle, or just because I know that a physician's knowledge of maybe what a certified recovery mentor does isn't the level of knowledge that a lot of us have. And so upskilling them on how that's a actual value add and would be a good resource. So I'll put a pin in that one.
So I think we've covered the need for 24/7 access, which hopefully will be coming through the Behavioral Health Resource Network and a few other resources we heard about now. We know staffing is an issue for everyone. So if you know someone who wants to work in methadone intake, send them to one of our clinics. And then we learned about some of the other barriers that our methadone clinics are facing. Are there, and we'll work on advocacy about those things. Are there other challenges that are coming up for anyone, whether it's the hospital-based program, the OTPs, or anyone else that's in the community in trying to connect people for methadone?
A big thing for me is, this sounds like it shouldn't be the case, but often the emergency department is maybe the last to know or close to the last to know about changes that are going on with community resources. And that's really frustrating because we're often the first point of contact for a lot of these people. And we don't get updated, lists of resources, or I just recently learned a couple of weeks ago that intakes had been really difficult to achieve at the methadone clinics. So it would just be great for us if we could have all of our community partners kind of keep the hospital involved in major changes so that we can give the best information to our patients. The social workers and case managers, discharge planners usually know more than I do, but again, for me, they're not often available at the times that I work and I'm seeing patients. So it'd be very helpful for that. And I'm happy to be a point person for that if there is a big change in any of the clinics or other programs, just to let me know and I can pass on to my partners, and I'll put my email down in the chat as well.
And I would certainly encourage, if you have someone like Melissa or another social worker that you wanted to have attend this meeting regularly, all of our providers give updates to what's happening in their programs. And so that might be helpful as well.
And as much as I do dig this meeting, I almost feel like there's a need right now, seeing how we can better connect with our OTPs from an ER setting. And I would love to see if there was a way that could happen where you guys can really talk shop and go inside baseball and speak about the different barriers and needs. Because there might be either assistance in terms of how that works, but between the partners that have spoken today, I think it's really timely. And I feel like you guys already made progress in just the 25 minutes that it was discussed. So that's just my 2 cents from the outside.
And I think that's one of Dr. O'Keefe's hopes too, that a spin-off from this conversation can be that we identify who the players are and really try to get that dialed in a little bit better.
Yeah, and I think it's important for us at Medford Treatment Center and the 2 local hospitals to maybe increase our conversations and I mean I'd be open to meeting more regularly with you folks if that's something that needs to happen.
Well, I like the suggestion of someone who's representative from social work continuing to participate in these meetings. So whoever I should be reaching out with to make that happen, let me know. And then Dr. Holtz, we can certainly then make sure we're, sharing that information regularly with ED.
Rochelle, can you just get Melissa's contact information and then add her to the distribution list for this meeting? I will, yes.
And then I think Kyle and Asante, you guys now have each other's contact information. And Kyle, I can share your contact information with Providence as well, since they're not here today.
Yes, that would be appreciated. Thank you.
Sure. Any other thoughts or comments on this?
Just one comment. Is it possible when Kyle finds out the source for the regulations, like whether it's state or federal level, if he could get a hold of Eric and we could get an email or some way of notifying us where it is coming from, so we could start initiating some action to try to address the problem?
Yeah, I can definitely do that. I'll do some research when I'm in the office tomorrow, because I think there's a couple of issues that we might be able to raise as far as induction and things like that. So yes, I will get some information and I'll reach out to Eric.
Yeah, I'd really appreciate that.
Yeah.
Well, I very much appreciate everyone's willingness to come together for this meeting and talk openly through these things. I always feel like open communication and collaboration moves our community forward in really positive ways. So thank you for what you guys do on a daily basis and then for coming together here today. Much appreciated.
Thank you, Dr. O'Keefe, and to all of our guests today who were willing to share and contribute to trying to find some different solutions for this. So very much appreciated. All right. Next on our agenda, we have the Jackson County Recovery Network update. And I think Lana McGregor, are you the new contact for this particular project?
No, Julia and I agreed to facilitate as neutral parties. So we're just facilitators. I don't know if Lori is on.
Lori asked that we take over given the update. So this is perfect. Yeah, thanks, Lana. I think, yeah, to Lana's point, what was decided at last meeting was that All Care and JCC would co-facilitate. And so the next meeting is this Friday. Is it this Friday, Lana?
Yeah, it's Friday.
Yeah, this Friday. And we have some additional entities that have been invited to the meeting. There's going to be clearly who were burn recipients and then who are additional guests that have been invited. But we have asked that if you are a burn recipient, that at the very least, there is always a delegate from that entity, because there will be important issues discussed, decisions made, and just collective work moving forward. And it'll be important for every entity to always be represented at that meeting. We also, during last meeting, compiled a list that we can, once we've passed it by the group, that we can send out so that everyone can see really simply and clearly the amounts that each entity received for burn funding, and just a brief 1 to 2 sentence description of how they plan to use the funds. So I think that's important to share with everyone. And that's going to be one of our first things, in addition to identifying the priorities of topics, in order of priority that we need to tackle as a JCERN, a Jackson County Resource Network. So that work is going to be moving forward here starting on Friday.
And starting off, it'll be two meetings per month. So they're going to meet quite often to get all this stuff worked out and prioritized. So.
And Lana and Julia, not to, I certainly don't need to know any of the details, but have agencies locally received funding for burn-related projects?
Oh, yes.
Okay.
Yep. Yeah, it's mostly our local agencies that have received funding. Up to that, almost 18 total of 18 million.
You mean like, did they have the money in their hands yet?
Yes, the money in the hands is what I was
Oh, the
getting at.
money in their hands. Good clarifying question.
Thank you.
That's a really good question. I have heard here and there of folks definitely wrapping that up and getting it in hand, but I wouldn't be surprised if not all have. Lana, do you know any specifics?
I don't believe they have yet, but I'm not certain.
Not sure if that's the most important question, but I think it will be important for the agencies stepping up to do the work and ramping up their teams to make sure that they can accommodate the work.
Oh, I do know. I know that some agencies have already began the work, like understanding that the check's in the mail. So I think they've hired some staff and are doing some things, but I don't know how much is in their pockets yet.
Gotcha. Thank you, Lana. Any questions for Julia or Lana regarding the process? All right. Well, I thank you both. However, our next item on our agenda is CCO updates, and both Julia and Lana do represent that, as well as Darren is here. I don't believe Jeffrey Piacitelli was able to join us today, but if either of your agencies would like to go in terms of CCO updates, we would love to hear it.
Yeah, Darren is going to give our JCC update, so we can start with that one. If you're ready, Darren.
I'm ready. Really interesting discussions. It's been a great meeting. So just a few updates for quarter 3. I'll be reporting on a few different things. First will be the SUD Recovery Summit, focused on opioids and overdose. Just a few things happening in that space. And then just a couple of general, or one more specific CCO announcement, and then an exciting new role that we have here at JCC. But here's what we collected for the Q3 report outs for the SUD Summit Action Plan. United's closed loop referral platform continues to grow and provide providers in the network are joining this tool and being onboarded. We have a quarterly newsletter that I don't have a copy of now, but if those that are interested, we can get a copy of that that will give updates on the Unitas initiative rollout in our county. And then JCC is we're holding discussions with both Providence and Asante around the funding for an on-site opioid use navigator, which is an exciting position that we've actually had success with in the past, many years ago. So someone to be at the hospital and help navigate kind of these situations that we just were talking about. So more to come on that one. We continue our SUBLOCADE pilot that's going to go, that started on September 1st of this year, and we'll go through 12/31 of next year. So for increasing access in SUBLOCADE, so we'll be able to report out on that as we gather more data. And then we already did a report out on the JCERN, so I'll hold off on that. And then we just wanted to, Julia might have mentioned this in the last report out, but JCC and our school-based school-based health strategy work group, internal, has done 2 rounds of surveying of the 7 districts in the county, and the last previous 2 school years. So something that came out was an increased need, as wouldn't be a surprise for most, but we don't talk about use SUD a lot in this group, but we know that rates have increased, and resources are limited, and at best, if I talk from a school personnel perspective, they really don't know what resources are available to them in general. I mean, I think some districts are better than others. Kind of what prevention strategies are working, we're seeing a lot of naloxone on campuses now, but just like none of that is coordinated. So we're hopefully, well, we're planning on holding a behavioral summit focused on school access on February 10th of next year. So we have a steering committee that consists of public health, Jackson County Public Health, Oregon Department of Education, OHA, the local ESD, and then we'll be in some of our treatment providers, as well as Lana and her team on all care. So just wanting this to be an effort, one of our first efforts, at least from a CCO lens, to kind of address this issue, and we'll report out on that as those plans become more clear. And then the other thing is we're going to be hiring for hopefully early next year for a SUD specialist on our team at the CCO level. So we're really excited about that, and that position, as we learn more about that, we'll report out to this group. So it'll be a new added resource to our team at JCC, but also to the network, and I think in the work that we all do together. So I think that's it for now.
Thank you, Darren. And Lana, any updates from AllCare?
I just want to add that, I'm excited to work with JCC and all the schools and partners to really jump into learn about our youth substance use disorders and, how things have changed in the pandemic. I think it's really timely, and a lot of services have, been pulled out of schools over the years, even pre-pandemic, and prevention efforts and stuff. So I think it's a good conversation to have all together to figure out where we need to be in this new age. And at a, kind of state legislative level, the Oregon Council on Behavioral Health is also looking at youth substance use disorder numbers statewide and capacity, and trying to have those conversations with legislators as well. So it's good timing.
Lana, quick question.
Yeah.
Regarding those youth substance use numbers, is there a presentation that they're making statewide that we could potentially glean from?
They're building one now. They're kind of parceling CCO data from different areas, and then the minimal statewide data, and then program data that they have. But it's, there's not a lot of youth accessing treatment. The need is, out there, but we're not really seeing it in the claims systems really. So they're trying to kind of piece different information to tell the story. But definitely, yeah, when they're done with that, I can certainly make sure this group sees that.
That would be great. I think there'd be a lot of discussion and perhaps system building discussions that we could have regarding that subject. So thank you.
Yeah. And then I don't really have anything specific. I don't know if Jeffrey didn't mention anything specific either. So I will just pass it along. I do want to, I appreciate the conversation too, Dr. Mann, and I'll be sure to touch base with our pharmacy folks like Mark Cantor and start those discussions where CCOs, where our role is in, and, the medications, and helping to take down any barriers that we might have in the process too. So I think thanks for that.
Thanks for bringing that up. Do you currently have, well, you don't need to answer, but one thing insurance companies do need to look at right now is making sure that re-examining the upper limit of dosing, if there's any upper limits on dosing for buprenorphine currently in the age of fentanyl.
Yeah, especially.
No,
that's something that I definitely wrote down, that the dosing levels seem to have changed a lot. So, and I don't know if there are quantity limits or dosing limits, but.
Thank you for that, Dr. Mann. And thank you, Lana, for bringing that up. All right. So local treatment providers, we'll just go down the list and start with the Addictions Recovery Center. Nathan.
Thanks, Eric. So we have our female residential unit back up to full capacity, full census of 14 patients. We currently have 2 infants in the facility with their moms, which is really great. I've been able to place in place there versus in community foster care. We're also have our detox unit, fresh start detox and sobering back up to a full census. That we've been able to do that because we've been able to actually hire some staff, which has been really great. We also are about ready to launch our pilot IVAB program in our residential facilities. We've identified a male and a female patient at Asante who are going to be working on transitioning into residential with support of Mercy Flights, and they'll be coming to help them with their medications and intravenous antibiotic medications. We also have brought back the majority of our outpatient group of employees and have outpatient groups happening on campus. We also have our assessments happening in person and intakes happening in person with a telehealth option as well for individuals who aren't able to make it to campus for whatever barriers. And I think that's about all I have for an update today, Eric.
That's quite a bit. I appreciate it.
Thank you.
Is Boulder Care with us?
Yes. Hey, everybody.
Justin.
What an awesome presentation. And I worked at OHSU at the Impact program, and that was a blast many years ago. And just awesome things and collaboration I like to hear. For us, two slightly cool things. We just hired someone, her name is Sarah Lafferty. Some of you might know her. She's in the area. And so it's nice to have, one of the Boulderites in the area, which is cool. So Brandon can breathe some fresh air, that we won't rely on him for every single thing. And we are, and of course, say I'm not a doctor, but we have developed also a quick start method that's very similar to what we just heard, where someone Narcans themselves and then immediately gives themselves Suboxone. And so it's something that it's peer reviewed and it's something we're doing, but yeah, the world is changing in the way that we look at how we can help people and not have to make someone be miserable for 3 days or 2 days or 5 days. We just get it done. So it's miserable for a couple hours. Literally in the instructions it says, and after you stop puking, then you put in the Suboxone. So but it's just fascinating to hear everybody and how they're trying to tackle this. So yeah, that's the only updates for us.
Thank you. All right. HIV Alliance, Dane?
Sure. I don't have any information on the peers. I apologize for that. I know they're busy down there, but I don't have an update on their data. I do on the naloxone. We did 25 new clients, 78 refills, had 31 overdoses reported and distributed about 373 doses. The remarkable fact is 40% of the clients on those refills, they had a successful reversal. So that is trending up across most of our counties down south. That, we used to be about 25% of the reason code for refill was a reversal and they use the kit. Now it's trending up. So that means more, which I think is probably, there's good and bad there. There are more overdoses happening, but more lives are being saved. But so the more naloxone we get out there seems to be a better result in reversals. So that's pretty much my update. Just trying to save lives.
Dane, thank you for all that you do and for the update. Appreciate it. All right, Sarah, we still have you listed as our La Clinica update.
That is true. I left there about a month ago. I've given a couple of people a heads up that it would be great for them to come and report to the group. So we'll see what happens. I'm started at Oasis this past Monday.
That is exciting. And well, congratulations on your new journey. I think that's going to be
thank you.
Important work for sure. All right. Was Julia or anyone from Max's Mission able to join us today? All right. Kyle and the team at Medford Treatment Center, we have heard quite a bit from you, and it's been, I've been trying to take notes and keep up, but is there anything else that you'd like to add?
Yeah, I'm still here, but I don't really have anything additional. I mean, I think we had a great conversation today, and I think moving forward, there's still a lot of conversations to have. And I put my email in the chat, and if anybody has any questions or wants to tour the facility or wants to collaborate on anything, we are more than willing to to come together and try and do the best we can. So I appreciate everybody listening to us today.
Awesome. Thank you. Let's see. We also have, is anybody from Oasis here, or Sarah, you could update today?
I guess the only thing I could say is that there's many new people starting at Oasis, and the move has been mostly completed to I think it's 525 East Main. There's quite a bit of room in there for there's a really cool play area for kids with like electric jellyfish that Carrie came up with. So anyway, there's a lot going on, and I just encourage you to drive by and see where it is and talk to us about it. I'll be working with Jeremy, I think mostly on harm reduction, and another nurse started who's done more clinical primary care. She's worked with Dr. Acevedo, so she'll probably continue to do that.
And that's across from Hawthorne Park along Main Street there.
It is, by Forage Coffee,
Okay.
Another landmark.
Those landmarks can be helpful. All right. Thank you, Sarah. Appreciate it. All right. Let's see. Eddie, on track.
Hello.
Hey.
Eric, it is so good to see you. I was not here last month. I just had to tell you, what a joy to see you again. I think Raquel presented for On Track last month, talked about the exciting SAMHSA grant that we got in collaboration with Oasis to deepen the care for women, pregnant and postpartum women across both of our organizations. So that's exciting. Eric, I can harken back to a question you asked earlier. Speaking only for On Track, we have received Measure 110 funding, burn funding, money in the bank. At the contract I was looking at for Josephine, it was a 40% of the total initial payment and then quarterly payments for the next 6 quarters. So I'm assuming it's a similar structure for people who receive. So there is money in the bank being used. For On Track, all of our programs are open except for Mountain View Recovery up in Hugo. We had initially closed because the fires got very close and moved those clients down here. Now, for the sake of rebuilding the program and opening with a full staff, we are just trying to hire. We need 3 program managers. We need 1 for the Hugo residential facility. We also need 1 Grants Pass outpatient and Medford outpatient. So I know we're all hurting for staff, but if you know anybody who's ready for a program manager position, we'd love to talk to them. And just sending all my good vibes to everybody on the call.
Thanks, Eddie. And I know that there's probably not an agency on this call that's not been challenged by hiring and building their programs up, but I like having that problem right now, that we have funding and resources are there. We just need to grow our community-wide capacity. So
absolutely.
Yeah. All right. Thank you. Oxford houses. I believe Chris is here to talk about Oxford.
Hi guys, I do have a short update. We opened our 16th house in Medford this past month. So we have 4 women's houses and 12 men's houses, 130 beds total. We sit between a 3 to 9% vacancy with those beds. So I'm planning on opening another men's house by December 1st.
Chris, that's amazing to think that our community is blessed to have those beds for folks who are so in need, and that Oxford's able to create that environment. So thank you so much for all the work around that. And to hear another house open up is always exciting. So very cool.
Thank you, Eric.
All right. And Reclaiming Lives, Stephanie. Or Brandon, but Stephanie.
Hi, Brandon had to go to another appointment.
Okay.
So happy to see you all. Let's see, we also received burn funding, 40% and a quarterly payment. So we have money in the bank now, which is great. Using that for expansion of our regular cafe services, and then our El Camino Ciguero, which is our culturally specific cafe. So as I mentioned last month, I believe we did sign a lease on October 1st for the Rogue Organic Cafe restaurant. And so starting November 14th, we will have more hours of operation with the cafe doors open. So just gonna go slow at first and do 3 to 5 on Monday through Thursday. And then of course we still have our dinners on Sunday, Monday, Tuesday, and Thursday. So looking forward to seeing what that's like, having people be able to be in the space and find a safe place and socialize and do homework or work the steps or talk with peer support. That's kind of where we're looking to engage people. I don't know if there's anything else. I think that's all I had for this time.
That's great to hear, Stephanie. Thanks for sharing that. No, much appreciated. Did any of our partners from OHA join us today? Mike Marshall. All right. Sarah Smith, is there anything about the naloxone work group?
This past month, we had a presentation from Corinne Richardson. She's the mental health and substance use disorder pharmacist at the VA. And it was a really interesting story about navigating organizations, people's beliefs, talking to the veterans. The naloxone has been free for quite some time, but there still wasn't uptake. So how they use motivational interviewing, got nurses involved and so on. It's pretty inspiring. And I'll say that meeting in a way is kind of like a safe space. Like if you're having challenges in an organization, or you just need somebody else's ideas, like when this thing happened, this is what other people did. It's a good place for that. It's the first Thursday of the month from 9 to 10 in the morning. And it sounds like we'll be presenting at the Oregon State Pharmacist Association meeting in February. I think Corinne is kind of running with that. So we welcome everyone.
And before I turn it over to see if Commissioner Dyer has any final comments, are there any public comments today? All right, Commissioner Dyer, any final thoughts for today?
Well, again, I just want to say thank you. Great conversation. I appreciate all of your work. Sorry, I was late. I don't know why. My schedule had the meeting down for 3:30. So to make up for it, I'm going to sit in this Zoom room alone for half an hour after you all leave. But no, I appreciate it. Thank you all, and we'll see you next time.
All right, and that concludes our meeting. And thank you, everybody.